Well, good morning, everyone, and welcome back to the second day of the Cuminating conference. Lynn and I are observing this. Where is Lynn? Right there. How relaxed some people look. So now those that went first are feeling pretty good. And we're really looking forward to hearing the second half of the presentations as well. It's my pleasure to welcome you all here again, and I have to say that coming in this morning, coming into the campus was just amazing. This is my favorite time of the year on the campus, and as we usually do, we like to just begin by recognizing that we are learning and being present on Coast Salish lands and pay our respects to the Coast and Strait Salish people on whose territory we exist. So to begin this morning, we have a special guest speaker, and I will just proceed and turn the mic over to Charlotte Redding, and she will do introductions and we'll get underway. So thank you, and I hope you enjoy the day.
Thanks, Lori. Morning, everyone. It was nice to see you all last night. Carmel and I in our little introvert's corner, afraid to go and speak in the crowds, but I really am happy to see everyone. I'm just a severe introvert that can speak to a crowd, but not in one. So it is my distinct pleasure to be able to introduce Richard Jock to you today, who is the Vice President of Policy Planning and Strategic Services of the brand new First Nations Health Council of BC. And he's going to talk a little bit about that. But Richard is a Mohawk of the Akwesasnes. I'm married to a Mohawk from Tyendinaga, and my ancestry is Mi'kmaq. So we are ancestral enemies, but present friends. I got a lot of ribbing when I married a Mohawk. Before accepting the position with the First Nations Health Council, he was the Chief Executive Officer of the Assembly of First Nations, and for 25 years has really contributed his leadership skills to governance and leadership in First Nations organizations across the country. So as the VP of Policy Planning and Strategic Services, he leads areas such as health actions, federal provincial partnership development, strategic community initiatives, business development, health policy, communications and community engagement, as well as quality assurance. So he's not very busy, so coming here today is not too much of a burden from his time. So I just want to say how very grateful we are to have you here, and how important your wisdom and your information will be to these students. So without further ado, Richard Jock.
It's okay, Mohawks are used to being enemies with everybody. And in fact, my partner is an Ojibwe, and the way that they used to scare their kids is they'd say, Mohawks are coming. So you can imagine the kind of stories that they say about me behind my back. But, part of what I had to do is learn some Ojibwe, just self-defense. So, but I think that that's an interesting point, because I think that some of those old rivalries and those histories, those are interesting parts of our past. But in fact, we're putting those aside, and we're really able to work in collaboration and in partnership in many ways that I think are really well beyond what we would have anticipated. So I think that as well, I just want to reflect that there's been some important leadership consolidation in BC development of a First Nation Leadership Council and bringing together voices that are different, bringing together folks that are in favor of modern day treaty making, those that are opposed to it, and being able to still work together really is an important foundation to where we are with healthcare today. Because if you think back 10 years ago, you wouldn't have seen that sort of collaboration, working together, which to me is an unprecedented development, but also is key to such development as a First Nations Health Authority, which provides services across the whole province. So I think that that's a good comment, and it's a good segue into some of the discussion for today and the developments that are underpinning some of this important work. So there we go. As I was preparing, and I do know a couple of the folks here pretty well. Jeff Redding and I go back quite a ways, and I like to think that we started and have done some interesting things together, both at AFN and in other places. And also Lillian Bain, who I've known and worked with over the years. And one of the interesting developments that I was reflecting on as I was looking at today's discussion was the so-called Romanow report on the future of healthcare in Canada. And it's, and in particular, the Aboriginal issues within this. I think it's interesting to reflect back on some of the points made in this report, which really were done as a result of some work that Mr. Romanow, and of course assisted by Lillian, did with the National Aboriginal Health Organization, where we really tried to pull together some of the thinking and some of the thinkers about what would be the future of healthcare. And some of their points were to consolidate Aboriginal health funding from all sources and to use those funds to create health partnerships to manage and organize services for Aboriginal peoples and to promote Aboriginal health. To establish a clear structure and mandate for Aboriginal health partnerships to address the specific healthcare needs, to improve access, and to increase training opportunities for providers for our services. And then part of that was to assure ongoing input into direction and design of healthcare. So interesting points, and you'll see I'll relate those to where we are today. The other, I just want to reflect as well that there were a number of other activities which also contributed to where we are today in BC and more broadly nationally. First of all, there was a First Ministers meeting on health in September 2004. And really, for the first time, Aboriginal organizations were directly involved with the First Ministers meeting. And it was very significant as well because there were a number of lead-up meetings and events which contributed to that and which led to, for the first time, a focused national discussion on Aboriginal health. Part of the outcome of that, interestingly enough, was that those individuals, and really as a collective, what people said at that time was that Aboriginal health was also in large part reflective of the need to address the determinants of health. So we kind of took it as an excuse at the time that people didn't necessarily want to deal with health care. But in fact, and it may have been, but I think as well it did set the stage for a broader discussion of not only health care as a way to improve the status of Aboriginal people and First Nations people, but also that we really needed to deal with the housing and education and other critical matters. So it really set the table for further discussion, and you'll see there was some subsequent processes for this as well. This also led to the need for detailed work to be done by First Nations and done by First Nations with provinces with respect to looking at details about how to have the various systems work together. Part of the recognition is that there was that part of the problems facing First Nations people and Aboriginal people in general is that there's many jurisdictions, and at times the jurisdictions pass off those responsibilities either consciously or unconsciously, which result in gaps in healthcare and result in lacks of improvement in health outcomes. So these blueprints were worked on over the period of a year, and for the first time there was looks at how can First Nations work with provinces to start addressing some of those interests about cross-jurisdictional approaches to healthcare. So it's an interesting development. These were then contributed and led to a year-long discussion process where we looked at housing, education, economic development, and the other part of it was relationships as really fundamentals to improving healthcare. So again, if you reflect back to the First Minister's meeting, you can see that there was a continuation of interest, and that the Kelowna, or at least the activities leading up to Kelowna, were intended to come up with those answers to those broad questions of determinants, but also specifically what to do about healthcare. So the Kelowna Accord in 2005 was quite historic in that there was really a remarkable level of consensus discussion with really the top leaders in the land, the premiers of each province, and Prime Minister, and the leaders of each of the Aboriginal organizations. So quite a historic development, and contrary to positions by some, this was not done in the back of a napkin overnight. Unfortunately, though, this in general then was not followed up on by the federal government. There was a change of government within 2 months. But again, I have to salute the foresight of First Nations people, the Leadership Council, who actually, at that Kelowna Accord, signed their own relationship accord with Premier Campbell and Prime Minister Paul Martin. So that part of the Kelowna Accord really stuck. And this then really set the table for the work that we're going to talk about, which is the First Nations Health Authority and what it's doing today. I just want to acknowledge as well that there was, and there were other bodies of work, and I think for those that study this and look at this, the Royal Commission on Aboriginal Peoples had commentaries in general about the future needs of First Nations people and how to address it, and had some particular references to First Nations healthcare. And I do think that they need to be acknowledged, but I think these ones I'm citing here are much more detailed. And also the National Forum on Health did have some, which was a precursor to the Romanow Commission, actually had some elements which referred to creating actually an Institute for Aboriginal Peoples, which then subsequently was developed into both the CIHR, Institute for Aboriginal People's Health, and NAHO also has roots in some of that work. So we'll get a bit to where we are today, and really the First Nations, the tripartite First Nations Health Plan, really then sets the table for fundamental change for the improvement of health status of people in BC. It defines a set of founding principles that will really underpin and set the table for some of the new possibilities for healthcare and healthcare delivery, but also contemplates and moves on determinants of health. It sets up deputy minister tables at both the provincial level and the federal level to make sure that determinants of health remain on the radar and that there's a mechanism for addressing those and raising issues within those. And then it sets some clear goals for short and medium-term developments to implement this plan. So again, I think just want to reflect on that, and you can see again some of the origins and some of the roots of this showing themselves in the developments throughout this tripartite health plan, where it reflects the shared commitment to health and wellness. And I think that I want to emphasize here the focus on wellness. And that this is really something that I would say is quite a unique characteristic of the First Nations Health Authority. And in discussions with the Canadian Institutes for Health Research, what they've said is that no other health authority, regional or province for that matter, reflects that wellness interest. And if you look across the country, that is the case, and it is unique. So health and wellness, and recognizing again the physical, spiritual, mental, economic, emotional, environmental, social, cultural wellness of individual, family, and community. And even though we're focusing on programs and services, it really looks again at addressing root causes of some of those structural issues. A bit about the First Nations Health Authority. It's a first for Canada, and really it's the service delivery arm of the BC First Nations Health Governing Council. And there is a health council chaired by Grand Chief Doug Kelly. Some of you may know him or know of him, and he's really leads the political arm and the political interface between the health council and the political bodies within BC. And this is extremely important that all of these pieces fit together in a way that then makes the space for this First Nations Health Authority to be created and to be implemented. I just want to point out that last Friday, at the board meeting of the First Nations Health Authority, the Canada funding agreement was signed. And that's really a significant development in that is the funding agreement for the next 10 years, which sets out all of the terms and conditions, the increases, and all of the references, all of the details necessary for the First Nations Health Authority to fully take over all of the services formerly delivered by the federal government. So I think that's a really significant development. And the other part of this is there are sub-agreements which have been done as underpinnings of that in capital, in info systems, and there's 7 of these sub-agreements which contain an amazing amount of detail. To some extent, I would say there's more known about BC health delivery, more defined about it, than I would say even Health Canada knows about its own operations now. So it makes you kind of wonder at some point why such attention to detail. But nevertheless, it helps make sure that, and it helps provide some of the real specificity so that we'll be able to manage all of those issues and deal with the issues in a way that is conclusive. So I have to say that there's an enormous body of work, and I certainly think that the Health Council and the CEO, Joe Gallagher, really have put a tremendous amount of activity to finalize those, and to do so, I think, is really historic. So deciding that agreement's really something, and we hope to have an appropriate celebration sometime in June. But this really is the sign that this is a goal. That before that, this was all negotiations and possibilities, but this is a goal. So I think the other piece of that is that within the next couple of weeks, we'll actually be making reasonable job offers to the 240 public servants who will then they'll have the opportunity, and we're inviting them to be part of the First Nations Health Authority October 1st of this year. So quite significant. On July 2nd of this year, we will take over the resources for the non-insured health benefit program, which is also a significant development. This is a major program within Health Canada, and it comprises roughly 40% of the regional budget. That's the services for dental, pharmacy, medical transportation, eyeglasses, all of those services for all First Nations persons in BC, regardless of where they live. So this is really, at this phase, we're largely taking over services pretty much as is, but obviously the goal is to look at ways to improve that and to use business-like approaches, healthcare, evidence-based decision approaches in improving healthcare, not facing some of the same limitations that are there for the federal government, and looking at how do we benefit better at a local level, at a community level, and in some cases at an urban level, which previously has pretty much been left in the dust. So if I can just comment on these points here. When I haven't been with the Health Authority that long. I've been there since January. So I certainly have no credit for any of those sub-agreements, the CFA, so I can really probably brag about my colleagues with that. But one of the things that I think is really important, when I arrived within the organization, I really looked at this. This is part of our basic package. And from that, and I'll just go over it very briefly, healthy, self-determining, vibrant BC First Nations children, families, and communities. That's really our goal. And really looking at that in conjunction with the directives, which are community-driven, nation-based, increased First Nations decision-making, that we should improve services, that will foster meaningful collaboration and partnerships, that will develop human and economic capacity, be without prejudice to individual First Nations interests, and that will function at a high operational standard. And that our values would be respect, discipline, that we would value relationships, culture, excellence, and fairness. I felt I knew what the job was when I walked in. And to me, I think the work that's been done over the last couple of years then really sets the organizational culture, our directions forward, and really gives us some good insight into how we're to conduct ourselves. So I think that this is really the framework for these services, and I think that these are really excellent foundations for that. You see that as a context. Then one of the aspects that I would say we will look to in terms of some of the ready transformation of health services is that, that we will make a move to establish regional offices, and in particular regional directors. That's a bit unique in that Health Canada really was set up delivering services essentially out of Vancouver with folks located across the province. But they did not, their setup is not aligned, does not relate to the regional health authority structure of the province. So part of what the logic here is that we're setting up regions which are geographically paralleled to the regional health authorities, and that we're setting up these regional positions and a regional policy priority setting group, I would call it a council at this point, which then their job is to work with those health authorities to achieve additional resources, better coordination of services, and begin to work to improve services for the communities within each region. So these regional positions will be key interlocutors, and part of our work over the next months will be to do regional health and wellness plans. So we'll have detailed plans in each of the regions that then they will be able to use for further discussions with those health authorities and with us to make sure that they acquire the resources to improve services. We're also starting the process of alignment. So as I mentioned, a lot of the individuals that are part of the program oversight, management, et cetera, are in Vancouver. Well, what we're starting is team charters, and I don't know if that's part of your study, but part of what project management does is it sort of looks at how do you assign work within organizations, and team charters are an effective organizational tool. And we're using this organizational tool to make sure that each of these regions has the supports that are needed to, whether it be a physician, an epidemiologist, that they have access to health planners, environmental health officers, so that each region has a team with formal responsibilities to assist in developing the plan and in implementing plans, and as alluded, ensuring quality assurance associated with those services and those plans. So the development of these regional offices is a significant development, and we're beginning the process of reorganization by aligning at first as sort of an organizing principle and as an intermediary step. So next phase, we're meeting on this shortly, is developing regional envelopes or regional budgets, however you want to characterize those, so that individuals then will make decisions within those envelopes. So again, really, at this point, we're setting the groundwork for this transformation and improvement, and for the idea of focusing on high-quality services and attaining more services from our partners. And in this case, those partners are, in many cases, the regional health authorities and the provincial province-wide health authority. Just for example, even though we're not quite fully implemented, we have a project board with the province, and what we've attained already is that we have, in the first round, 16 nurse practitioner positions, which are funded by the province. And in the second round, we anticipate a minimum of 5 more, and we have another round to come probably over the next year. And in addition, there's the physicians with alternative pay plans, and there's been some new announcements about remote communities and other incentives for physicians to work in different kinds of practice. So we're on the ground floor so that we will have access to increased primary care providers. So already, even without fully being implemented, we're making gains, and our groups are making gains in terms of addressing those extremely important primary care resources. So, interesting developments, and you can see, again, as I refer back, and you start thinking about some of the points made by Romanow and others, you can see where some of these ideas are now coalescing into reality, and I would say will continue to do so. Now will be the time for a commercial. So I'll just go quickly through some other aspects, because I think while I find them interesting, I hope you will. I think part of the other sets of interests are as well is creating this wellness approach and having that wellness approach really entrenched throughout the organization. Our CEO has really made it a point that that each individual has to have their own wellness plan, each department has to have their wellness plans, and that our organizing principle has to be that we have to show and exhibit and do what we say we want communities to do. So I have one of these Fitbits on, which tracks my every step. I try to track every step, believe me. So my plan is that I try to do 10,000 steps a day. It might not sound like a lot, but it actually makes me get off the couch and do a certain amount of activity. And so part of that, and then the other part of it is dietary. I have some dietary targets and some weight targets. So that's my plan, and then my unit has a plan, and my department has a plan. And so like I said, the CEO is challenging our organization to exhibit that. Our health council, I don't know if you've heard it, Doug Kelly is, he's an imposing figure, I'll say. And what he's done is, there was an article about the health council, and they alluded to some of the leaders as beefy chiefs. So he's kind of flipped that around. So he's launched what he calls the Beefy Chiefs Challenge. And he's challenging all chiefs to have a certain activity level and weight loss goals for October. Again, we're using physicians and so on to do that, to backdrop it. But again, at the leadership level, he's challenging all the chiefs to have health as their own priority, and that, again, they exhibit that. Because the other part of this wellness approach is that we're all trying to be wellness partners with First Nations communities and with every First Nations individual. That there is a partnership there, and there's a responsibility there for those distinct actions to be taken. So again, I think that that's an interesting approach, and again, making sure that traditional knowledge, traditional approaches, traditional diets are all part of our interests and our approaches going forward. A further aspect of where we're at is, and I can see this starting to happen in my discussions with the First Nations and the Health Branch people already, is that the way governments fund things is in sort of programs, and they inadvertently create barriers or silos in terms of how services are being created and funded. And the other principle of the federal government, at least I'm not sure if this is true of the provincial government, is once something's created, you might cut it, but you never get to do away with it. So essentially, you have public servants delivering a whole range of programs, some of which no longer make sense, don't work together, and so on. So part of our funding agreement and part of our approach going forward is that we're not actually required to maintain these silos. So we're not going to just simply bash those down immediately, but looking at health plans, having people deploy those resources against their need, that is really the first steps in breaking down those silos and having services delivered according to need and according to what will also have effect within the communities. So the other piece of that is working with the partners across the health spectrum, integrating primary care and public health, and what's underway in most of the regions. Part of what's underway is that we're actually doing detailed mapping of services in each of our regions, which is quite an exercise, but it's really good so that we start seeing where the real gaps are in services. Because we really need to, as you know, stay away from generalities and get to the specifics. So this will help us collectively make decisions about how to deploy resources and to move forward. And to date, there is a role for traditional healers, but it's been quite limited. And I think that what is possible is looking at, well, what is the real role? Are there really prohibitions against us having traditional people on payroll? I mean, those kind of things which the federal government would never do because they felt there was a legal liability and a risk, we can do. I think that this setting the table for that and looking at some of the other developments that will have to accompany that, such as how do we regulate that, how do we recognize healers, what are the protocols, what are the safeguards, we'll have to do that part of it for sure. But this sets this possibility. And I think to me, that I would refer you to some examples in Anishinaabe Health in Toronto, where essentially they started out with physician services and they have totally migrated to providing traditional services, culturally designed care rather than doctors. Not a negative comment about doctors, it's just that those folks are available in Ontario. At least we call them Macmillan practitioners because there's one in every corner. But so there's access to those, but not access to a good system of traditional healing. So this was quickly seen as the way to improve services and improve wellness, particularly mental wellness. So I'll go just very quickly over this. How's my time so far?
It's 9:45. So you're still good.
So just to give you a bit of an illustration about what is the First Nations view of health and wellness. And I think I can't do justice to it, but the reflection in the middle about human being, I think that may look like a very quick statement. But in fact, in First Nations culture, being a human being is actually a very complex undertaking. That it actually reflects a very comprehensive and well-developed endpoints. And that it means that you care for your immediate circle and that you take care of that immediate circle. And then it means that you look to your neighbors, and then that you look to other nations. So it's a very comprehensive way of reflecting what is the center of wellness for Aboriginal people. So again, it's a very comprehensive approach. It's a very well-developed approach. It's a very philosophical approach, and it's a very much sharing approach. So again, having that as sort of the center of the concept, then you can see, well, this is an important aspect of health and wellness. And of course, the values are important, the reflection of family, community, the relationships of the First Nations first, and then our relationship to other nations, other First Nations, and of course to our province surrounding us, and to the rest of the country, and ultimately internationally. So again, very important. And I think as you look at what influences health and wellness among First Nations people, there's some very good studies that have been done which reflect this. David Chandler and Chris Lalonde show that really the connecting factors and the community elements are different and are much stronger a factor for health and wellness than they are for the other citizens of BC. And this study's been replicated nationally, so I would say that this also has national application. So again, seeing where those fits, I think is very important then as you look at how to address health and wellness for First Nations people. Okay, so outcomes. So if we're to look at where we're going in the short run and what we're working on, health services that are community-driven, nation-based, that we actually move to close what we would say is a 20-year gap in health status between First Nations people and the other citizens of Canada. And what I would say is that even where folks have done adjustments to those, the factors in those gaps, where they've taken out the elements related to income, education, all of the things that we would commonly say are the key factors, even when you take those out, there's a gap. And to me, part of what I explained that gap is the need for self-determination and making your own decisions. So to me, closing that 20-year gap, part of it is the ability to make your own decisions and to do so in a way that moves forward, is positive. And this is the next point, which is that First Nations really will be the decision makers around their health services. That we continue to look at and address in very concrete ways the broad spectrum of determinants of health, and that we continue to look at those issues through a holistic lens. That we really look at, and as I was starting to say, that we create some new synergies with health authorities, with universities, with some of the healthcare providers, that we create some new energy from those relationships and from those possibilities, and that we create new and improved pathways for care, and that we achieve our vision, which is healthy, self-determining, and vibrant First Nations children, families, and communities. One of the things that I experienced when I was at AFN, we had about 10 lawyers working for us. But as I traveled around and I just met ordinary people who really had no reason to say stuff to me, people would say, and this would be just a guy I'd meet at Walmart. I wouldn't say what I did, or I'd just say I worked for AFN. My daughter's studying Aboriginal law, and she really wants to work on it. She wants to make a difference. I thought that was really something. And what I would say is, and maybe we're there, it'll be really interesting if people start coming up to me and saying, my daughter, my son, wants to work in Aboriginal health.
probably be more, I don't know, I can't say it, but, and then are you guys looking for virtual hiring?
Two good questions. One is that we do have an Aboriginal Human Resource Development plan. And what we're doing is evolving that so that right now it's pretty broad. We have relationships with universities. But as you pointed out, what we want to do is to have a regional approach to health careers and health recruitment. Because really at the regional level, that's where the action is. So we're retooling our human resource development plan. So it'll be more focused on the real on the ground needs, and I would say those cover lots of areas. That they cover various aspects of nursing, physician. We are always recruiting Aboriginal health planners, and we'll be having planners in each of the regions. Physicians, as I mentioned, I think that there will be an increasing set of opportunities for people to work in First Nations community delivering primary care. We are also posting for a senior medical officer. So we have a wide range of interest, and we are retooling those to support those interests, both local and provincially. We have currently a grant program to encourage folks, as well as some co-op programs developing, and we're quite interested in placements, summer employment. But those things are really things we want to develop further, and what we're really looking forward to working with some of our friends and colleagues here at the university to develop better ways to do that. Some universities may actually be able to assist with placing health professionals in some of those, like I would say, particularly physicians can use locums and residents to be part of our system. So there's lots of ways to do that, and part of what we need to do, as I said in my presentation, is to develop some of those synergies and some of those partnerships so that we do that better. So I would say, is there a preference? I would say that what we would try to do is our first emphasis will be high quality individual. What we're saying is that regardless of what race you are, that part of our interest is having cultural competency as part of our organization. So all those that meet cultural competency, interest, being part of our mission, that's who we want.
Thank you.
I'm not sure if Lynn or Trevor was next.
Sure. Otherwise, we won't pick up the question.
Thank you.
Heard a lot about
So the first entry point we got is such an exciting and hopeful thing. Colleagues you have from the assembly and having had a wide perspective, a couple of questions. First of all, is this only going to happen in BC, or is going to happen across the rest of the country? I think you see it only happen in BC. I'm not sure where you can sense the rest of the country is in terms of readiness for this. And secondly, what are the implications of this for other areas such as housing and education and economic development, where you mentioned Canada and London, and control of those sorts of issues? So where do you see that going, both in terms of other policies around health and also standing mental health and some of those other life determinants?
good question, and I've heard a lot about you. I would say that I would say every month there's someone from another province coming to meet with the board and with Joe Gallagher. Saskatchewan, I would say Scotia, or Quebec. I would say Alberta is, has some possibilities. So I think I think there will be shortly other people making the moves. I would say Health Canada has really held them off at this point. They've put there's a lot of effort that's gone into this from their point as well. The discussions, negotiations, and hammering out of the details has been really, really intensive. I think they've said, well, we're going to do this one first, so everybody else will have to wait. So I would think that there will, there'll be some lessons learned from what we've done that they'll think about, and I would say that probably pretty soon another group will start. The second one on determinants.
Well, the implications for housing and other issues where First Nations should be.
Well, I think everybody's watching, right across from the spectrum of different kinds of services. Because I think that one of the things that I would say is that we're going to set up a pretty robust infrastructure as part of what we need to do. And really, any of the transformative, I would say a significant part of transformation will also be related to the degree to which we can have broadband connectivity and can start developing some of those applications. And I would say, of course, those then are quite broad in potential benefit outcome application. So I think that once this starts, then I think that this will create those set of opportunities. But I don't want to get ahead of myself, but I do think it's very clear that what we're doing, we're setting up financial systems, all those things, which to me are support broad possibilities.
Hi, I'm Lynn Davis. I also teach in this faculty, and I want to say first how exciting I find this, and I really appreciate your very specific explanation. I teach in the undergraduate program as well, so this is something on which we focus. My question picks up a bit on Trevor's, and that has to do with child welfare. As I'm sure you're aware, some nations here in BC have undergone what's been called devolution, so that they're responsible for child welfare. What kind of synergies do you think might exist between the authority and the child welfare systems, or lack of child welfare systems?
Another good question. One of the things that I've done in my past as well is I've been health director in Dusty, where we did transfer, we went uninsured. But what was also interesting is that I was director of health and social services, which included child welfare. One of the things, even though we were one department, one of the things that we experienced was that many of the clients are the same clients for social assistance, for child welfare, for alcohol and drug abuse programming, for mental health issues, and that basically there needs to be case management and breaking down the barriers to sharing information before you can really address those very particular groups. And when you work in a community, you know the families that help. So what I would say is there's a broader application to a province-wide system, is that we need to first start with aligning. We need to look at how do we break down some of those barriers. We need to look at common information sharing. And again, how do we make sure that some of the mental health program services are being provided, are coordinated with the services we provide. And I would say, what is the influence of culture, cultural development, cultural knowledge, and knowledge and part of a young person's ability to thrive after child development. And I would say that the statistics and the outcomes are very, very poor. So how can we address those? So similarly to how we would address our other issues, I think we would start with alignment. It would be good to start looking at MOUs and partnerships, and then see where it goes. I think that we don't want to have an imperialistic view about how to do things, that really we need to have it be cooperation, coordination, and effective working together, effective tools. And I think a lot of that, by the way, can be a contribution can be effective in those systems. So I think those sorts of things help setting the table for improvements, better service integration. So I would say that there's lots of room for that, and we look forward to that going forward. But again, I think it has to be a steady change process.
I think we might have one more question. I know Richard has a
So thank you very much. Really, really helpful. I just want to echo other comments about how much we appreciate you sharing this with us. My question actually it kind of extends the conversation stimulated by questions by Trevor and Lynn. You mentioned about information systems and so forth, the need to work together and think through different ways, the kind of mission mandate that you have. So my question really is to what extent at this point in the early development of the organization, have you been thinking about the role of research and evaluation, reflecting on, there's a great moment here of thinking about trying to get the information to help us kind of know whether or not the direction you set is kind of consistent with the goal or the aspirations that you have for the organization.
Good question. We've had discussions with Dr. Alan Beaudet at CIHR, with Michael Smith Foundation, and we're starting to have discussions with each of the big four research universities, and really what we want to do is develop really what I would say a competition-free zone, so that we can sort of lay out our approach, and let's work with the universities so that we can say, okay, well, how can you support various parts of that? Each of the university has their own strengths, and I think that it'd be really good to see how we could develop that plan going forward. Working with Michael Smith, I think that there might be some opportunities and avenues there with CIHR similarly, and I think it's an opportunity to develop a very unique research approach, to have it grounded or anchored in our organization so that we're able to really show evidence, show progress, and maybe even, well, not even, but use those tools to help improve our functions going forward. So I think that is our interest, and I would say we would love to do that fairly quickly. But I think we're getting expressions of interest from the different universities, but we want to make sure that it's framed and then actioned in a way that really is based on our agenda. So that might sound a bit egotistical, but I think it's not my belief. But I think it's more how we would see this being done and how it would be done in a way that would be constructive and exciting for everybody.
Well, thanks again. I just really wanted to just say how much we appreciate you being here and taking your time. So anyway,